Hello. Pepper is a 21-year-old university student who presents to Dr. Dog with concerns regarding a 12-month history of amenorrhea. She is otherwise well but has no significant medical or surgical history or recent weight loss.
Hello, Pepper. I'm Dr. Dog. At what age did you first have your period?
Hello, doctor. I believe I had my first period at age 16, but they've been erratic and only had light bleeding every 3 to 4 months. Also, if you were wondering, I've never been sexually active, and I'm a non-smoker, and I don't like drinking alcohol.
She denies a history of hysterism, vasomotor symptoms, and family history of early menopause. These are important parts of the full POI presentation, identifying that there are likely an underlying issue with the hormone levels.
Pepper, we will go through some of the clinical tests that help us to come to a conclusion about your diagnosis of POI.
Thank you, doctor.
Clinical examination is essentially normal, including a height of 164 centimeters, body mass index of 24 kilograms per meter square, and Tanner stage 4 breast and pubic hair development. Short stature and low sexual development outlines a low level of estrogen. Pepper is normotensive. Blood test investigations show an elevated follic stimulating hormone level of 54 international units and low sensitive estradiol, confirming on at least 2 occasions over subsequent reviews thyroid function is normal. This demonstrates that the thyroid is not contributing to the pathogenesis of Pepper's POI. The combination of prolonged amenorrhea over 4 months with an FSH in the menopause range on 2 occasions, at least 4 weeks apart, is consistent with the diagnosis of premature ovarian insufficiency. So far, the case is reflective of what we would expect in POI, with high FSH levels but no underlying metabolic disorders or autoimmune diseases, leaving the potential for Pepper having a decreased number of follicles from birth.
Doctor, not only is this diagnosis making me emotionally distressed, but these further tests make me think that more might be wrong with me, and I'm not sure how to deal with all of this.
Further tests were undertaken to identify if the POI is secondary to any other undiagnosed conditions. Pre-maturation tests were completed and the results were normal, as are the patient's adrenocortical and thyroid antibodies and colic serology. A pelvic ultrasound demonstrates a normal uterus with small ovaries and an absence of follicles. These tests did not uncover any underlying conditions, so long-term complications of POI were then explored to ensure maintenance of appropriate bone mass density for Pepper's age. DEXA showed low bone mineral density at the lumbar spine with a Z-score of negative 2.1 and a Z-score of negative 1.7 at the hip. So calcium, phosphate, and magnesium and vitamin D levels are normal. She has no other known cardiovascular risks, and her fasting glucose levels and lipid profiles are normal. Pepper shows low bone mineral density at 22 years of age, means there is an ability to gain bone mineral density back, as she has not yet reached the age where BMD would naturally start to decline in females.
The doctors talked to me about my diagnosis and the long-term complications or any problems I might have, and it seems like I might have problems becoming pregnant, and I must take hormone replacement therapy until I'm 51 years old, and this is relatively distressing to me. They've also asked me to remain in close contact with my treating doctors to make sure my treatment is adequate, and I believe this might impact on my life quite significantly. Not knowing whether the hormone replacement therapy will be working makes me feel very worried, and I'm not sure if I'm going to want to take them.
Pepper commenced transdermal combined continuous HRT. The consequences of POI on future fertility are particularly distressing for her, and she is counselled on the possibility of spontaneous ovulation in POI. Importantly, she is advised that her current HRT is not contraceptive, and therefore contraception is required if she wishes to not become pregnant. The patient is also referred to a psychologist for counselling. It is important that following up with Pepper by the doctor is frequent and that a psychologist is seen regularly. Following almost 2 years of hormone replacement therapy, a repeat DEXA scan demonstrates a 12% increase in BMD at the lumbar spine and a 9% increase at the hips. Pepper continues to see her psychologist and is managed by a multidisciplinary outpatient team and her GP. Management of women with POI requires a multidisciplinary team approach to address the psychological impact of the disease, initiate HRT and or contraceptive options, manage menopausal symptoms and long-term consequences to ensure Pepper is able to achieve the highest quality of life possible and manage her POI with support and continuity of treatment.
The last few years have been quite a struggle for me and a bit of an adjustment, but I know that I feel slightly better knowing that my condition is improving and my bone mineral density has also improved. I realize that the next few years will be quite a struggle, but I'm more accepting of my condition now. Thank you, doctor.
It's okay.